It's been a while.
It has been a while. I'm really excited that there's drilling and banging going on in the background of our recording.
I don't really know what they're doing out there.
I don't either, but it's probably somebody that's, trapped somewhere begging for help.
Well, I forgot to get the recording studio.
That's okay. It's fine. It's just as well. I mean, we can be...
It was completely my fault. I own it because I remembered that we had to meet today, but I didn't remember that I needed to get the recording studio.
That's okay. Do you think they've noticed that you spilled that lemonade in there yet? You have a gigantic lemonade today, so I'm kind of thankful we're not in there.
I told them myself. So this is actually sugar-free lemonade. I found at the QT. You have to go all the way to the other side, and you can get sugar-free lemonade. I love lemonade.
I do too, but I wouldn't do the sugar-free option. Good for you.
What are we going to talk about today?
I have a couple things to talk about, but our primary thing were these, pain out of proportion as a topic, and also like we have discussed kind of within there some EMS myths, which are interesting.
You need to explain what you mean by pain out of proportion, because when you told me that you wanted to talk about this particular topic, I didn't really understand what you're actually meaning.
Yeah, so there's like a subset of patients everybody has had in their ambulance or wherever in the ER that are like exquisitely tender, and like you can't make heads or tails of it. Like, why are they so tender? What is going on? And it's not like, oh, that person has testicular torsion. That's not pain out of proportion. That is proportionally painful. Like, their testicles turned on itself. Like, things like that make sense. You're in labor. Yes, you're going to have pain. You have a kidney stone. You're going to have pain. I'm talking about those people that you're like, what is going on? Like, why? So I have a couple examples to discuss with you. I feel like may give you a better example of what I'm talking about.
Are you necessarily also saying like those people that where the vital signs don't really match up with their pain as well, or are we talking about?
I think they could certainly fall into that category. Okay. And you can get in trouble a lot, right? Because then you depend on their vitals, and they're really on the metoprolol all the time, so they're never tachycardic.
Yeah, you're like, they ain't getting my pain medicine.
Yeah. Well, pain out of proportion is an irritating complaint, and it also, it's also a thing where I think from some people, and I'll tell you my latest example, we already kind of hate them when we walk in there because we're like, the nurse has already come up twice. They've only been there for like 3 minutes. They're complaining of significant tenderness and pain, and you can't really figure out why. So I'll tell you though, my typical kidney stone patient is pacing around the room, sometimes kneeling by the floor, rocking back and forth, vomiting, and explaining that they have this flank pain. Okay, I'm game. Like, that probably does hurt really bad. I've never had a kidney stone, but I feel like that would probably hurt pretty bad. And then you give them some medicine and they feel somewhat better. That's not who I'm talking about. Like, that in your mind, you're like, that's probably this. I'm talking about the person that, for whatever reason, is in there complaining of severe pain and nothing will fix it. And they, sometimes they've already been to the ER once, maybe twice. They've gotten narcotic pain medicine. They still don't feel better. And you're like, what is going on? So I had an example this past probably 2 weeks ago. Maybe it's 3 weeks ago now. Out at a community hospital I was working at. The guy was just there the day before or 2 days before that. Was a chronic pain patient, meaning he went to his regular physician, got a narcotic prescription once a month. He'd been on it forever. Doesn't normally come to the emergency room, but was there the other day, and it was complaining of chest pain that was like radiating to his back and shoulders.
How was his perfusion? Did he look?
He looked okay.
Warm and dry.
Yeah.
Okay.
He looked okay, but he was.
So I'm going to ask some questions because I didn't know this was what you were going to talk about, but I'm glad you are.
Yeah. He looked okay, meaning he didn't look shocky or something.
But he definitely looked uncomfortable.
He was uncomfortable, and he described, it looked like from the previous note, because I went in there with a whole different attitude, I'm going to tell you. I'm telling on myself because I want you to understand how easy this is to do. So it's the middle of the week, during the daytime, and I'm like, why wouldn't you just call your regular doctor? Like, you obviously go there. So I did call his regular doctor and was like, hey, does this guy, I'm trying to feel them out, like figure out like what kind of a pain measurement he's on, like blah blah blah. And
You're
then
already suspecting.
I'm already that person, and I'm like, why
that
are you?
Somebody's lying to you.
Yeah, you want narcotics or something, which I really try not to do. But like for this person, this is his second time in there in 2 days, and he goes to the doctor. So I'm like, why? Anyway, I end up calling there, and the lady on the phone says to me, he has an appointment tomorrow here, and she says he never misses an appointment. Well, I wouldn't either if I had a chronic condition and I went, but there's always that subset of people. There's that subset of people that use all their pain meds up early. They don't go and they miss an appointment. Now they need someone to figure it out for them. So I'm already in that mindset when I go in there.
Yeah.
Which is wrong.
A mindset that'll get us in trouble.
Correct. Oh, absolutely. So I go in there and I'm looking at this guy. He doesn't look acutely toxic or anything. He's able to talk to me. I read the prior person's note, and they talked about how he had chest pain, but it was really radiating up. And she talks about, in her note, the provider said he had electrical feeling down both arms. Well, if you told me that, I would rule out a dissection first. I don't really know if that's what she did. I didn't go into all that because in my mind, I was already thinking of different things. But that was her note.
Let's rehash. Chest pain.
Yeah.
That radiated.
Kind of up to the shoulders and back and down both arms, and described it as electrical. Like electrical shocks.
Okay, got my attention.
So I was like, huh. So then I go in there and I talk to this guy, and I was like, listen, like, I talked to your doctor. You have an appointment tomorrow with them. He's like, well, I was here the other day, and I really feel no better. And in fact, he's talking to me, and I'm examining him, and he's, moving his legs around, but can't get comfortable on the bed. And he's not really able to move his legs around.
How old was this guy?
50s. Not really able to move his legs around as well as I wanted. And right before I got in there, needed help getting into the bed, which I find interesting for someone that walks.
50-year-old, yeah.
And I was like, what's that about? But I still was like, well, maybe this is trauma. I've had people do weird things in the emergency room, so I'm like, well, maybe it's trauma. Anyway, I examined him. He's kind of like that uneasy, can't get comfortable, he's moving around the whole time look. And I'm like, So I examined him or whatever. He's got good pulses. So I'm like, okay, it's probably not. I guess if it was a dissection, he'd be dead 2 days ago. Probably.
Right.
Probably.
Right.
I don't know if she ruled out dissection. She probably did. I don't know. Anyway, they treated his troponins, all that stuff, blah, blah. He's like, well, when I got home that night or the next day, something like that, I fell trying to go to the bathroom. And I'm like, what? Weird. Look, and I just kind of filed that away. And I'm like, listen, here's what we have to do. Because now I'm going through my list of like pain out of proportion stuff, and I'm like, well, he still could be FOS, right?
What's FOS?
Full of, right?
Okay.
He could still be. But I'm like, well, maybe just being dramatic. Like, I'm going through all this. So then I say to him, okay, we're going to do MRIs, your whole spine. That's what we're going to do today. Here we are. I have an MRI machine. It's the middle of the day. We're going to look, because the only thing I can tell you is either you herniated a disc or you have an epidural abscess. It's got to be one of these two if you're in that much pain. And well, today he was saying like, no, his chest didn't hurt as much, but man, this like electricity down his arms is bad.
So the chest pain is
now that's kind of resolved this.
But now we still have pain.
Still got down in the arms,
tingling
in the back,
pain down the arms.
right, in the back and the neck. Okay, so I send the MRI with and without contrast
today.
So I tell him, listen, Mark, he's like, well, I don't really know if I can do it. I'm like, well, you can't even get up and walk. So what else are you going to do today? That's actually my answer. And he's like, well, okay, I mean, that's what you said. I was like, yeah, I think that's what you need. I give him some, I want to know what catches my attention. As I'm turning to head towards the door, I was saying out loud, hey, you had that appointment at your doctor's office tomorrow for your refill of your pain medicine. He said, well, I couldn't even get there if I wanted to. As soon as he said I couldn't get there if I wanted to, I was like, something's wrong with this guy.
Yeah.
They never miss those appointments.
Yeah.
Like, something bad's happening if they miss that appointment. So I was like, oh, shoot.
But let me stop you for just a second. That's really, really good that you had the intuition to think that. Do you know how easy you could have missed that, though?
Yes.
You could have missed
That's why I'm talking about it, because this is a pain out of proportion case, and there's a whole bunch of diagnoses to back up a little bit that pain out of proportion. Epidural abscess is absolutely one of them. Providers get sued for missing this all the time. All the time. Epidural abscess is one of them. The ischemic gut, another one. There's the cardiac reasons that kind of are in the non-traditional referral patterns. That's another one. There's just stuff that you're like, the migraine that you wrote off as something really was a head bleed. There's things with the pain out of proportion. Epidural abscess is like right up there. So anyway, I MRI him. Look, or his blood work doesn't look terrible. CRP and sed rate are a little bit high. And I'm like, okay. No elevated white count, but I'm like, okay. CRP and sed rate are kind of non-specific, but I'm like, they get my attention. Anyway, I'm not going to change my plan. Give him pain meds, IV pain meds, and all that stuff. Anyway, the MRI comes back that he has a C3, C4 epidural abscess. And he has to be emergently transferred to have neurosurgery.
Talk to pre-hospital people, because, when we talk about the MRI, what did it look like? What did it show you? What all did you find out from that? Because we don't have, that.
So these are people it's always pain out of proportion.
Right.
Like, legitimately. And interestingly enough, they used to say, and I get why, IV drug users are number one. This guy's not an IV drug user.
Right.
But they are in the big category. But so are other immunosuppressed individuals, people that are on chronic steroids, people that have HIV and cancers of sorts, and people that have diabetes. Huge risk factor. Oh. Now, there was an EMS provider locally that had an epidural abscess that was also missed and then was found within 2 days. Yeah.
So this happens frequently.
It does. They say it's rare, but I see stuff that happens. You know what I mean? That just happens. But I remember hearing the story of this provider, and it was something like he thought he tweaked his back at work, which you could see doing.
Right.
And it wouldn't get better. Well, then he couldn't move real well, and so then he came in. He had some kind of, they were like, maybe it's a disc hernia. Then he had the proper study, and they found it. And he did. I think he was recovering well, but it was a big to do. So when you see these people that are pain out of proportion, you're gonna think use other stuff. Like this guy, I went in there with a preconceived notion because I was probably tired that he was, BS. This is for pain meds, blah blah blah. He was just seen and had a pretty thorough workup done. A pretty thorough workup for not the diagnosis.
Right.
That's a problem. So if there's any central neurologic stuff, they couldn't walk. They needed help getting up the stretcher where they never need that kind of help. They couldn't pee properly.
Can I stop you for a sec?
Yes.
Because you have provided a lot of extra things that you would be able to determine.
Right.
Now we should talk about without the MRI machines, without everything else, the key indicators of things that the story you just gave me. I didn't know this story from Adam. You didn't tell me this story.
No.
But let's take this case right here and let's talk about the things that as an EMS provider you can pick up on, because you don't have the MRI machine. You don't have the diagnostic equipment. And this is where I wanted to take some time and feed off of the two of us. So guy comes in relatively healthy looking. He doesn't look that he's going to die.
He's not going to die
but
acutely.
He looks like he is in a lot of pain.
Yes.
And helping a 50-year-old man up on the bed where you can examine him should be an indicator.
A person that normally walks, I think the guy still works. That's weird.
You have to pick up on the fact that is a sick or not sick. This is a sick individual.
So this brings us to the further discussion of how does one educate on sick versus not sick? That is an impossible question to answer.
It is.
Honest to God.
But listen, okay.
But, yes.
So I'm not asking for you to give me any HIPAA regulations or
No.
whatever. No. But if all I have is a 12-lead vital signs glucose, is this guy able to waiver or is he sick?
He's
based off of the vital signs.
Pain out of proportion should bother you, but I will tell you, this gentleman had a heart rate of 115. I'm like, why does your heart rate jump up every time he moves? What's that?
So you did have something concerning. You had that heart rate.
Well, then I was like, does he need an opiate withdrawal? You can look like that then.
Right. So we keep on going. We got the guy. We're helping him up. And you have the gumption to call his provider.
I do.
Sees somebody.
He does.
He sees somebody. So the provider tells you
he never misses an appointment.
he never misses an appointment.
And I was like, ooh, yikes.
This ain't good.
No. And then when he said, well, I couldn't have made it to that appointment anyway, they never miss an appointment. People that are on chronic pain meds, they usually don't. The other thing is, I think as a pre-hospital provider, pain out of proportion should bother you, period. So I talk about, you know, the AAA is definitely on the list of pain out of proportion. Seriously. I mean, for a good reason. But, like, when you look at them externally, you're like, can't really. You know, the epidural abscess, mesenteric ischemia, volvulus, and all that weird stuff that happens in the gut, all part of that, in my mind, of pain out of proportion. Like, when you physically look, like, if you had an impaled fence in your side and you were, like, screaming in pain, I'm like, yeah, that's probably appropriate. That's not pain out of proportion. That's proportional.
So let's go back. Because we're going to find this patient.
Yes.
He's going to be in the bed.
Yep.
He is.
Yep. Or the recliner.
His wife is going to have called because
Yep.
he's not getting any better.
Yep.
He's talking about missing his doctor's appointment. She's concerned. We're going to find this patient in the bed.
Yep.
We're going to find him trying to get comfortable.
Yep.
We're probably going to find him with a heating pad somewhere.
Somewhere.
And when we go in there, we're going to find this patient. How are we going to find his vital signs? If he's not moving around, let's go back to the patient that day. I can't remember, or I never knew what you had.
Yeah.
So how was his blood pressure?
It was higher. It's actually like 150 over something.
Okay.
But I attributed that to he's uncomfortable, but he does have hypertension.
So as EMS, we can go in, because at first, you know, you were talking about, you know, AAA or whatever, so you're thinking about that as a differential. So to our pre-hospital providers, we could come in and we can get a blood pressure, but we can dig down deep into that because a lot of us are going to go to that AAA, right?
Yeah, or you
AAA,
might see this guy like
dissection.
dissection. You might think STEMI. I mean,
Yeah.
there's a lot of things.
Yeah, there's a lot of
Yeah.
dissection.
And you have to
AAA.
do those. You have to do the
So
EKG.
ruling out both sides,
You have to.
know, making sure. So then they go ahead, they put the patient on an EKG monitor. As long as he's not moving, is he running silent?
Like 90s.
But when he gets up to move around, he gets tacky, right?
Oh, yeah.
Okay, so as long as he's not moving, as we're putting the stickers on, we're really not getting anything remarkable.
Correct.
So all the remarkable stuff is what
That's right.
he's saying.
That's right. And then is to ask that next question. Now, I mean, I think a lot of EMS providers in this area know by now that I always need closure on things. And I ask really dumb questions all the time that people think are really dumb, but to me, it's because I'm like, yeah, but, and sometimes it's just for my own, I need my own closure, but most of the time I'm asking them for another reason. So, like, case in point, when there's a stroke, people are like, oh, when's the last time you talked to her? Oh, 7 p.m.? Okay. Then I ask the patient, did you get up to go pee at all in the middle of the night? They're like, yes. I'm like, were you fine then?
I like that.
Yeah, or like, did you call anybody else on your cell phone? Did you text anybody? And like, you can pinpoint better that way. Or for this guy, the fall bothered me at home. Like why did you fall there? It's like my legs won't work. My legs are weak. My arms are on fire. I was like, that's weird.
Everything that tells you this guy needs to be in a hospital is because what he said.
Yes.
Not what you found. It's what
Right.
he said.
It's what he said.
So the reason why I guess I'm being so passionate about that is because how many times as providers, I bet you've done it too, especially in your younger days where you come in and you're just following the motions, you know, putting that poor lead on.
Oh, yeah.
And the things that they're saying, you ain't picking up on
That's
because
right.
maybe you're tired, maybe you're whatever. I'm telling you, what people say it will steer you
I think
sick
that's true.
versus not sick.
I think that's true.
It's part of it
It's gotta
because it's not sick.
Yeah.
Might have been, you know, this. I mean, think about in the height of COVID, this guy's going to be in triage.
Oh, yeah.
You know,
He might have been in triage anyway.
Yeah.
Yeah.
So, really good way to start this pain out of proportion out, and we're going to come closer.
Oh,
I'm not
sorry.
gonna bite you.
Sorry.
So let's go ahead and get into. Thank you so much. I really like that introduction there.
The case?
Yes, ma'am.
That really happened to me. It was the truth. And you know what the other thing was that I thought you may want to find interesting about that case. 2 days ago, he drove himself. Today, he took an ambulance.
And see, that stuff's all that stuff makes sense to me. The one question that is so hard to ask because you're trying your best not to ask it like a jerk hole is what changed today to make you
Oh,
call
yeah.
us? Because I feel like they look at you and be like, well, you didn't want me to call you? No, I just want to know what made you call us today,
Right.
because you've been dealing with this by yourself.
Right.
So we'll go into these particular cases of pain out of proportion. I'm going to throw some out there to you, and we can go ahead and talk about our diagnostics, talk about what we're going to find with these patients, talk about things that concern you. You can share some stories too. But these are based off of the ones that you told me when we were going to plan this. Let's go into these 4, I guess, pathologies. Is that what you'd say?
I guess, yeah, they're on my list. Now, I mean, it could be expanded to include a bunch of stuff. Like, I mean, in some people's mind, dissection may be pain out of proportion, although, theoretically your aorta is blowing up, so.
Right.
Shingles could be pain out of proportion. I suppose a kidney stone to some other people is pain out of proportion.
The thing about dissection, it's not going to be pain out of proportion for long.
No.
So,
All right.
First is the one you already give a little bit of background on, your epidural abscess. So so what is happening here?
It's a collection of infection. Usually, well, I say it could be anywhere. It could be in the lumbar spine. I've seen it most often in the lumbar and the cervical, but I suppose it could be thoracic. I think they had a case even at GMH that was a thoracic all the way up to the cervical, that missed the MRI lumbar because the lumbar didn't. They MRI'd from the lumbar spine down. They didn't see it because they didn't scan that part.
Is there a certain population that's more susceptible to
Okay, so the answer will be
epidural
IV drug user,
You
but
said
not
Why?
because they're injecting stuff into their. I mean, they're literally injecting stuff directly, and they're not. It's not the cleanest, right? And then they can get endocarditis, which can also seed various spots, including that epicardial, or epidural region. So diabetics, immunocompromised, like untreated HIV, chemotherapeutic patients on chemotherapy, and then you just get like other people that have no reason. Now, if they're instrumented, meaning they had a surgery, that would make sense, right? And then there's some people that just had an injury, and for whatever reason,
That's what I was going to ask.
bacteria goes there.
Okay.
Like, and maybe it's in their system already.
What
And bad dentition, that's another thing.
What things are we going to find on scene where these people that are experiencing pain out of proportion and the patient is suffering from epidural abscess? What are things? You know how you have those things like on registry testing where they give you that question and you should know that that's what's wrong.
Yeah, it's probably going to be the IV drug user, honestly, but and more than that, it's going to be extremely uncomfortable, cannot get comfortable. There's usually a neurologic component, like they can't walk because their legs are weak. They have that shooting pain down, both arms and legs or something like that. It's usually they can't pee, so they've got like some kind of neurogenic bladder situation going on. There's other reasons, other things usually with it, but the pain out of proportion is really one of the main symptoms.
Is it going to be like this guy too, where we have? Do you guys typically see that upper chest pain with the?
I suppose, but I've
radiation?
heard a lot of. It's usually complaining of severe neck pain into the arms, that kind of thing.
Okay.
For the cervical one.
Okay. All right. Mesenteric ischemia. What is this?
The low flow state into the it's abdomen. So think of elderly people that have just eaten food and get severe abdominal pain. A lot of the time it's from just there's a low flow state there. Now you've eaten. Now you need more blood to go to your abdomen. You don't have more blood to go to your abdomen, and it's like a heart attack in the abdomen. If that makes any sense. Just like a heart attack of the brain is a stroke.
Yeah, can you get a little further into it though? Like, I guess.
So you get chronic like mesenteric ischemia, which means like you have to eat small meals throughout the day. They're already aware that you have it and things like that. And then you get like an acute attack of mesenteric ischemia. There's another way besides low flow. You certainly could have an acute arterial clot there that would cause that problem as well.
So what's happening?
That's the other thing we should add to our list is an arterial clot. That's
the food doesn't go to the digestive system.
Yeah, you don't get the blood. The blood. Sorry, this is my ADD here. the blood flow doesn't able to keep up. It's why your heart. It's why your
Hence
chest pain.
ischemia.
Yeah, that's what I mean. So it usually on an examination, they're pain out of proportion. I mean severe abdominal pain. They're writhing around. Their lactic is usually high. Their CAT scan will look abnormal.
Okay. What about fever?
Plus or minus.
Oh, so nothing really telltale there.
But their belly's going to hurt pretty bad.
Okay. Distension?
Maybe.
Okay. All right. Rebound tenderness with any of that?
Oh, they're tender. I mean, straight up, they're miserable.
Okay.
Writhing around.
All right. AAA.
Yeah, AAA, I've seen more often than not as suprapubic pain. I think I have a UTI and back pain.
You're kidding.
Yeah, a lot. But I had a guy, he passed away from it, but he was in Greer with me, and I had just gotten on shift later on, and it was crazy. It was a ridiculous day there, and the nurse had been asking repeatedly for pain meds for this guy, and he's like in his 80s. And I was like, that's not good. Why is that guy in so much pain? So I went in there, and I actually always palpate people's feet because I find a lot of things from perfusion there, and he had pretty cold legs, and I was like, this is not gonna be good. And he was ruptured AAA, but he was writhing about abdominal pain.
What kind of findings on scene are we going to see with these patients?
I mean, just keep in mind the abdominal pain that's kind of out of proportion, back pain, that makes no sense, suprapubic pain that's not like dysuria, doesn't have cloudy pee, doesn't have a history of UTI. Like, if those patients are complaining of pain, also, if somebody never calls you and they're calling you, something's wrong. This is not going to be probably not the frequent flyer, right? This is going to be somebody that's so this guy never called EMS, I mean. And then he had, when I looked at his legs, and his legs were hypoperfused. They were cold.
That caught your attention right
Yes.
away. Volvulus.
Volvulus happens in kind of a couple groups. There's pediatric volvulus, which can happen, and they're inconsolable, usually young infants. And then you've got so volvulus is a twist on itself, like a torsion of the intestine, if you will. And you can actually Google a picture of. I have to add all your. Really, this is a list of the pictures we need. I don't know why I need to make you another list. But the volvulus actually has this coffee bean X-ray that's kind of goes with it. If you Google it, as weird as that is, there's a coffee bean look to the rest of the air that's in the intestine. But if it is twisting on itself, and so you get a couple groups. So there's infants and very young, the very, very young. Okay. Then there's the marathon runner. Not kidding. Read about it. There's a marathon runner that has acute onset of horrific abdominal pain. And then there's the older females.
What do they do for these patients?
Go to the OR. I had a lady at Greer that had this, and
do they cut them out?
Yeah,
They
have to
cut them out.
They have to because now if you had
because
volvulus,
they don't have the blood flow.
Now they're going to have
mesenteric ischemia.
Right. But this is not going to get comfortable.
And it dies, and it just
See what I mean?
I've learned a lot from you.
Have you?
Yeah. Arterial clot.
Oh, I love the arterial clot because vascular never believes me when I call them. You're thinking. I know you remember hearing all of this when you were learning, painless, pallor, cold. It's poikilothermia or something like that.
Yeah,
some weird
6-piece.
Yeah, that.
Paracentesia or whatever.
Right.
Yeah.
It is amazing to see in person. I don't know if you've ever seen one of these. Those arterial clots, especially in the legs and stuff, is where we normally see them. They are screaming, and their leg is white.
Really?
Yes.
So also within the pain out of proportion.
Yeah, it's not like they injure themselves. They didn't. But you're thinking also, with any of these people, the mesenteric ischemia and these arterial clot people, if you ain't thinking, do you have AFib? Remember how AFib makes you prone to strokes? Mm-hmm. They make you prone to strokes in other places too.
So when we talked about that probably, I guess, it's probably about 3 months ago, and you kind of were like, "Hey, why do people with AFib have a stroke?" So also, having AFib makes you prone to a lot of these
mesenteric ischemia, arterial clots, all that.
the things that it doesn't say on the prescription bottle.
Correct.
AAA. One thing about AAA that I'd like to talk about before we finish up is the unequal blood pressures.
You mean the unequal blood pressures in the arms?
Mm-hmm.
Because now you're thinking of dissection.
Well, they say you can have them in AAA too, can't you?
I thought you would have unequal blood pressures, meaning you would have higher blood pressures in the arms and low blood pressure, like basically nothing in the lower part.
Let's read what this says right here. So this is pretty neat. So the cause of, typically associated with a dissection. The cause of just my
I
bad.
think there's somebody made a slide one day for you calling dissecting the dissection.
It was. Yeah, we can throw
No,
that in there.
this makes sense.
Yeah, this is cool. So with the typical dissection, the cause of unequal blood pressure or pulse deficit in the upper extremities in this population, typically due to the dissection of the brachial, cephalic, or subclavian.
So if those are dissected, that blood pressure there is going to be markedly lower than this blood pressure here.
I love when you touch my
Oh,
subclavian.
stop. Because this arteries are all intact.
Okay.
Makes sense?
Yes, ma'am.
See that?
We'll go ahead and put the dissection up there. So we can put that up there. Is there anything else today that we want to talk about with pain out of proportion? If not, we got to move on.
No, I think that's good for a podcast.
I do too, but we got to talk about. Are we going to talk about some myths?
We can. Sure.
We got a little bit of time.
Okay, we can.
We got a little bit of time. All right, so.
All right, some EMS myths that I thought I really want to add one to this, but I wanted to let me cover a couple of things. I'm gonna bring this up in a minute, I guess. All right, so this is a huge list. We don't have to do all these, but we can do the EMS myths of epi, meaning. And I think when we said this, we meant like the cardiac stuff.
Why are we still giving it?
Well, you mean because everything's come and gone off of ACLS 1,000 times?
Yes. And because people say the only two things that, increases CP1, CP2 outcomes is aggressive CPR and early defibrillation. Those two things.
Why do we intubate then, too?
I'm not going to get into that with you. I'm not going to get into that with you. I just done a full. I'm not going to get into that with you.
Come on, what's your opinion?
I think it. So.
I guess a cardiac arrest.
I'm going to tell you.
Let me be specific about it.
Okay, I'm going to tell you my opinion. So you've been around EMS for a long time, right? So EMS has went from double paramedic to double basic to
basic and paramedic.
Basic.
Yeah.
So the days of dropping a tube in every cardiac arrest, I think has to be gone. And let me talk to you why. All right, so it is situational. It is situational.
That's fair.
It's situational. If I go in there and I'm working with an EMT and this is a witnessed arrest, meaning I go in and he goes down the
all efforts.
Yeah,
he
goes down. Yeah. You know what I'm saying?
Got it.
He dies in front of me.
Yeah.
I don't see how I'm going to be able to intubate that patient with early access to what we say is important, epinephrine.
Sure.
So are we going to say it's important or are we not going to say it's important? So if it's not important...
It's not as important as those compressions and defibrillation.
And if it's
Absolutely
not, then maybe I do have time to intubate the patient. But if early access to epinephrine is important, then I cannot, if I'm working with an EMT, be the one that's intubating the patient. If it's important.
But I'm glad that we made that distinction because maybe just say a simple cardiac arrest, if we can call one that, is the type of thing we're discussing. The other thing is, what if you have a respiratory driven arrest, meaning there's vomitus in here. There's like, it's not like an asthmatic that took too long to call. That's not what I mean. Some like obstructive process, then maybe you have to intubate. Agreed. You have to do the compression.
Situational.
Yeah, right. Yeah. Situational, like you said. Now, would it be easier for you to roll up on there, start the compressions, or have them start the compressions? You shove an eye gel or whatever, a King Airway, whatever it is, down in there. If it's easy to, okay, then roll with that for a while.
Do you understand what I'm saying?
Yeah.
Because I really do think that you are the doc to be able to pick up on what I'm saying here. So as I put this illustration on the screen, all right, so 2023 ambulance crew, right here. 2023 ambulance crew. Typical, most of them are going to be stick figure paramedic.
Yes.
And stick figure EMT. We do still have trucks that would be 2 paramedics.
Yeah.
We still have trucks that are 2 EMTs. We have trucks. But we have that. It's not always the same, and that's why I say it's situational based. So I take this truck, and this is me working on this paramedic EMT truck today, and I go out, and I find my patient either in cardiac arrest or either close to being in cardiac arrest. So let's take the patient that is in peri arrest that goes down the chute and loses pulses there with me.
Okay.
He's in peri arrest. I couldn't do the things he arrested before I could,
do
intervene.
anything.
Right.
Yeah.
So I get to this point, the patient arrest. I have fire department personnel. Maybe they're ALS, maybe they're BLS. They're probably BLS.
Well, they're helpful.
Let's just be honest.
Okay, they're helpful.
They're probably BLS, right?
Sure.
So let's just be honest. With the demographics in the area, they're probably BLS. All right, so I got 3 more people, right?
Yeah.
They can that are the BLS level. They can do compressions. Sure. They can do airway. They can do.
They can
let's see.
Can they do the IO?
They can't unless they're ALS. And there are a couple.
But you could do the IO.
I could. Well, I can if I'm intubating.
But you're not going to intubate.
I don't know.
You don't know yet.
It's situational. You
got to look at the situation.
Yeah.
So what does the research and data say?
All right. So research and data. What I do know about the research is the 2 things that improve CP1 and CP2 outcomes are early access to CPR.
Yeah, early compressions.
High quality CPR.
That's correct.
And early defibrillation. So this one is the one that's in question. Is early access to epinephrine important for these 2 outcomes?
Probably not.
Are you willing to go off of probably? Because
I'm going to give
there's
it
a reason
once
that
I do
we
these
still
things
get
start.
it. Yeah,
right.
Exactly.
Right.
So if early access to epinephrine is important, then you really got to think about the order of operations.
Right. Yeah.
Because you are the only provider that can drill. You're technically the only provider that can push that medication. We have multiple devices in this county that are supraglottic of nature that are wonderful devices.
Yep.
Wonderful devices. So my recommendation is get the situation under control.
That's
first.
right.
Put in the Biad.
Yeah.
Put in the IGEL.
Right.
Put in the King.
Whatever. Yeah.
And then if you've got to come back,
then you can do
copious secretions, vomitus.
Fine.
Innovate.
You reassess. That's fair.
But you got to get them back first.
Yep.
So I always think about what I would want for me. Or actually, I love my wife more than I love me. So what I would want for my wife to be done. And I think I would want them to get the situation under control.
Yeah,
and then
that's fair.
allow them to think through it.
Yeah, that's fair.
I'm not trying to be.
No,
like,
it's
tell
a
you
good thought. It's a good thought.
All right, so moving on. So
Let's talk about this since we brought up drilling somebody.
tibia versus humeral hyo. Well, now you got the distal femur for the pediatric.
Yeah, which you know is some pediatric surgeons and trauma surgeons.
They don't like it.
Correct, but we'll come back to that.
All right, so the humeral head is the way to go.
Absolutely.
Humeral head's the way to go. You're gonna
5 to 7 liters a minute,
and you're right there beside the heart.
It's stupid not to.
Yeah, but let me tell you, I've drilled this.
I know.
In an adult.
Everybody did.
In an adult.
Yeah, everyone's
You want me to tell you why?
Because it's where you got access to.
It is.
Yeah.
Everybody was at the
head.
airway. I couldn't
got
get
you.
up there.
I got you, boo.
Couldn't get up
Let
there.
me tell you what the best thing is. Do we have one in here? Is there a training one?
There is.
Here. Okay, Mike. So when I train people,
Mark's out of the office, by the way.
oh boy,
I just can't.
to use the IO, and they're like, I can't get to the head of the bed. This is what I tell them.
Oh, so they're gonna move then.
If you do that in somebody's ear, they gonna move.
They're gonna move.
All right. Okay, and I think to round it out, our last little myth, or is this weird thing of the targeted temperature management.
I don't know anything about it.
That's now what they're calling it. But
It's still in the ACLS program.
is it TTM? Is that how they label it?
Yeah, it is. It's still in it. Well, excuse me.
See?
It was in it
See what I mean?
the last time I took it.
Right.
But it doesn't really specify what they're talking about.
I think
it's the fact that the center has the capability to do it.
That's right. And so I remember the days of cool everybody. Then it got more specific of like specific parameters. And now it's TTM, which, is basically 32 to 36. Basically, the idea behind there is they don't want them to get a fever. Fever it increases cell death, makes the body work harder. And so that's their point.
Have me and you talked about this before?
No.
Okay. Well,
I don't think so.
Somebody I talked to this with about it, and they told me that exact thing, and after that it made sense.
Yeah, so I guess what they look at now is, was it a witnessed arrest?
Okay.
Was it a shockable rhythm? How long was the resuscitation? I think they're looking at it from a standpoint of what they would look at for anything else. Like, how is this futile, or is this going to end probably with brain death, or is this something that can be assisted? And so they do this. It's called. They don't want to say cooling because it's to prevent fever more or less, which may incorporate maybe a cooling blanket or Tylenols and such like that. But it's not as aggressive as it once was. We had like an Arctic Sun protocol and everything where I practice.
Cool. Now that I guess that probably is the last thing that we'll talk about today.
Yeah, I think that sounds great.
I think it actually really good, really fun sitting here talking to you. I learned a lot, especially with the epidural abscess case that you presented at the beginning. I appreciate that. The other thing is, hope I didn't piss anybody off about the
I'm sure we did.
endotracheal intubation versus
no,
the
somebody. You can never make everybody happy.
I'm just telling you that I would rather the providers take that minute and use the personnel that are on the scene in order to get the situation under control.
It's really hard, though. What I have noticed is for some paramedics to give away tasks. Very difficult for some of them to do it.
It is.
They have to.
It is, but also not just paramedics, but EMTs too. Double basic trucks are huge now with a shortage of EMS personnel.
Sure.
And it's basic life support, the thing that does not change.
Right.
The thing that hasn't changed for a long time.
Right.
The thing that has worked to save people's lives. Epinephrine, amiodarone, lidocaine, that shit comes and goes.
Yeah, oh God, it does come and go.
But one thing that is hitting hard, that is staying the same, is high quality
compressions
CPR,
and
airway,
defibrillation that's early.
and defibrillation, circulation. So the general ABCs. So if you don't think that you're part of the team, that you're part of the EMS team, that you can be because you can't put a tube in, you need to check yourself.
I had a conversation just this past week with somebody that was like, they really like intubation. And I was like, who cares? Like, good for you. Me too. But if I need time, I need time. Like, I
Right.
can do something else.
You need everybody on the scene has to be providing feedback and actions
Right.
in order for it to go, and that's what they expect out of us. When you call 911, they expect trained professionals,
Right.
no matter what your certification level is.
That's right.
All right. Till
Cool.
next time.
All right. Till next time.